In this video, we're going to discuss NSAIDs. NSAID stands for non-steroidal anti-inflammatory, and these are drugs that are both non-prescription and prescription used to treat pain, fever, and inflammation. So as for pain, it's called an analgesic. For inflammation, anti-inflammatory. And for fever, it's called an antipyretic. So let's discuss how these drugs work, and then we'll look at some individual drugs and where they work. So let's look at this muscle cell, and what we're doing is we're zooming in on the cell membrane. And like all cell membranes in the body, they're phospholipid bilayers. And you have the phosphate heads, which are charged. They have a negative charge, so they're going to interact with the water around them. And then you have the hydrophobic long fatty acid tails, 2 for each phospholipid. And this is where we get our precursors for pain. Is arachidonic acid is a 20 carbon molecule that is cleaved off this fatty acid tail, and then you can begin the cascade towards prostaglandins, which are the actual molecules that sensitize our nerve cells to pain. So let's imagine you have a tissue injury. That's going to activate an enzyme. The enzyme's name is phospholipase A2. So it works on a phospholipid, and you see the A suffix. So it's an enzyme that works on a phospholipid, and these are the ones that cleave off the arachidonic acid, which you can see the chemical structure for here. Now, to get to a prostaglandin, there's another step, and it's initiated by a cyclooxygenase. These are enzymes, and we call them COX enzymes for short. There's a COX-1 and COX-2 for 2 separate little pathways to get different prostaglandins. So arachidonic acid gets acted on by cyclooxygenase, and that facilitates and catalyzes the reaction to lead us to different prostaglandins. One thing to make note of is that the diet we eat can influence the amount of prostaglandins we produce that are anti-inflammatory versus, these pro-inflammatory molecules. If you eat a lot of omega-3s, those omega-3s actually work their way into those fatty acid tails of the phospholipids in the cell membrane. And the same happens with omega-6s that are pro-inflammatory. And, especially if you're having some type of chronic pain syndrome, those omega-3s can help from the root to prevent these prostaglandins from being made. All right, starting back at the top. So the 20 carbon molecule called arachidonic acid is an icosanoid. These are 20 carbon molecules. And whenever there's an inflammatory stimuli, phospholipase A2 gets activated. It goes in and cleaves off that arachidonic acid from the phospholipid tails. And this enzyme is actually what gets blocked when we take corticosteroids, which is a potent anti-inflammatory. And the reason we don't take these all the time, even though they're a little more potent anti-inflammatories than NSAIDs, is that they come with a host of side effects. And but this is where they work. They block phospholipase A2, a step higher than the COX enzymes get blocked. So corticosteroids, some examples of these that are used clinically are prednisone, dexamethasone, hydrocortisone. And basically these are synthetic molecules that mimic our natural hormone, which is cortisol. And cortisol is made in the adrenal cortex, the little gland that's above the kidneys. It's a little kind of triangular shaped gland, and it has an outer section called the adrenal cortex, and it has an inner section called the adrenal medulla. And these molecules are made in the outer part, hence the name cortico for adrenal cortex. So let's say that you didn't take a corticosteroid and phospholipase acts on the cell membrane to cleave off arachidonic acid. And then once it gets to arachidonic acid, we're just going to look at the linear version here. It could go one step further and become different prostaglandins. So our two enzymes that do this are cyclooxygenase 1, cyclooxygenase 2, COX-1 and COX-2, and there's several different prostaglandins that can be made, and these two we'll talk about on the next slide because they're important in the blood clotting process. Prostacyclin prevents blood clotting. Thromboxane accelerates blood clotting or induces blood clotting. And so we want to kind of have a balance between those two, and we'll see how that works on the next slide. So here, NSAIDs can block COX-1 and COX-2 enzymes. Sometimes they block them evenly, and we call those non-selective NSAIDs. And sometimes they'll be heavier to one side or the other, so they might be COX-1 specific or COX-2 specific. They're going to work on both enzymes, but they just may work on that one enzyme more than the other. And why does that even matter? Well, nobody wants a heart attack and stroke, I don't think. So this is a balance that needs to be considered by the clinician and the patient, is that on this COX-1 side, if you block a COX-1, which a specific medication that's heavier on this side is aspirin, what you do is you block the platelets from making thromboxane A2. This is the abbreviation for thromboxane A2. If you listen in that name, you can hear thrombus, which a thrombus is another name for a blood clot. And platelets, they produce thromboxane A2, but if the aspirin binds to it, then it'll prevent it from making thromboxane A2 for the duration of its life in the body. And I think it's around 7 to 10 days, or 5 to 10 days, somewhere in there. The platelets, that's their lifespan, and they're not a full cell, so they can't make new proteins. So they're pretty much done as far as producing thromboxane A2 once a COX-1 inhibitor binds to it. So thromboxane A2, if it's available, if the platelets produce it, it causes vasoconstriction and aggregation of the platelets. So all this moves toward a blood clot. On the other side, on the COX-2 side, we have endothelial cells, and these are the cells that line our capillaries and blood vessels. They actually produce prostaglandins, and one that they produce is called prostacyclin or prostaglandin I2, and this one causes vasodilation and aggregation. So two important aspects to that. I'm going to shut this door real quick. My dog's barking. And so you want to watch that balance very closely. And one thing about the COX-2 side is when you block that enzyme, it will have more of an influence on the joints. So the COX-2 enzyme produces prostaglandins that cause joint pain. So if you have a patient that's suffering from, say, rheumatoid arthritis, then you would definitely want to block the COX-2 side, but still be aware that you're messing up this balance a little bit. And that's what happened with Vox, is that people started having increased heart attacks and strokes because this balance was off, where the prostacyclin was blocked and the thromboxane A2 wasn't. So you had more of a more platelet aggregation than you would want. So here's different medications and where they fall on this spectrum of COX-1 to COX-2. So all these on the right lean towards more COX-1 selectivity. So for example, aspirin. A lot of people will take that when they have cardiovascular disease because aspirin will block the COX-1, so it's blocking more thromboxane and tipping the scale over more towards prostacyclin, and it's vasodilation and preventing platelet aggregation, so that it does its job as far as a lot as an antiplatelet to help prevent heart attack and stroke. And some others that are used clinically are ketoprofen, indomethacin, naproxen. All these lean a little bit more to the COX-1 side. One thing to make note of with COX-1 is that another prostaglandin is made by through this side, and it helps protect our stomach from the hydrochloric acid. And if you block this and take, some of these COX-1 inhibitors too long, it can have a negative effect on the stomach lining and eventually ulcerate the stomach lining. And if it even gets bad enough, it can work its way through the stomach lining and lead to, internal hemorrhage and bleeding. So ibuprofen, this is one that, that's used quite frequently. And notice how it's right on the line. So it's nice because it inhibits both COX enzymes equally. So you get a equal influence, and you don't really have to worry about thromboxane A2, predominating and leading toward platelet aggregation. Whereas some of these that are used a lot for, different arthritic conditions. So this is Celebrex, diclofenac, meloxicam. These all lean towards the COX-2 because they're better. One, they're better on the stomach. So, you always have to take food with aspirin, and you worry about that prostaglandin that increases the mucosa, the mucus lining of the stomach, and protects it. So these are better on the stomach, but theoretically, they tip the scales just a little bit more for this thromboxane on this side to predominate, and a little bit more of a risk towards a heart attack or stroke. I believe that clinically they still wouldn't be used unless if it were like Box, where you had a pretty significant difference, but it's just something to kind of keep in mind. And I think that's about all I want to say about this video, and I'll see you on the next one.